Welcome back to Your Health television program. I'm Dr. David Morwood. I am a board-certified plastic surgeon. I'm pleased you could be with us for our next segment. We have the illustrious Dr. Mark Howard, orthopedic surgeon and fellowship-trained spine surgeon. Dr. Howard, thanks very much for coming on the program.
Thanks for having me, David.
Dr. Howard, it seems like back pain, neck pain is ubiquitous. It seems like everyone at one time or another will experience back pain, low back pain, mid back pain, or neck pain. Now, why is that? Why is back pain so common?
David, it's actually the most common cause of visits to the physician, and actually the most common cause of days out of work is back pain and back injuries. The reason being is that the spine is really the internal core that really supports all the forces that go through our body. It's a complex anatomy that really has three joints at every level, so there's multiple areas of stresses. The disc is the major shock absorber or cushion between the bones. We also have joints in the back of the spine, the facet joints. There's a lot of forces that go through there, and as we age, unfortunately, the normal structures in the back, they deteriorate, they become more prone to injury. The good news is most of those injuries are soft tissue injuries. They're benign. They tend to get better just with time and healing.
Okay, so you said, Dr. Howard, around every vertebral body there are three joints. Is that right?
That's correct.
Okay, so the disc, let's teach our audience about the disc. Now, that's a wafer of cartilage, is that right? And that goes in between the vertebral bodies?
Yes, the disc is a soft tissue, not a bony structure. It's between the bones of the spine. And if you will, it's a little shock absorber. It helps to transmit the forces between the vertebra, but it's plastic and pliable and allows our spine to move, which obviously we need to do. It has two portions. There's an outer tough fiber called the annulus. That's a very tough, kind of gristly material. Then there's an internal, more of a cushion or a pillow called the nucleus pulposus, and that's really more of a shock absorber, if you will, like the shock in your car.
Dr. Howard, it reminds me to some degree of other joints, like, for example, in the knee, there's a meniscus, right? Now that's kind of that's a wafer of cartilage that can be easily torn, and when it's torn, it can be uncomfortable. Is that the same type of situation? Can a disc around the spine tear, and is that what you mean by slip disc or a ruptured disc?
Well, they're similar. The anatomy, of course, is different. The meniscus is more of a horseshoe-shaped cartilage. It's specially designed to fit between the two ends of the bone and the knee joint. The annulus, or the disc, is similarly, it's custom designed to fit that space, but in a very analogous way, we can tear those structures in the same way that you sprain an ankle or strain a knee. Again, the great news is that the majority of those injuries do get better just with time and natural healing, and only a minority of those injuries go on to become symptomatic or cause pain longer term, say longer than 6 weeks.
Okay. Now, Dr. Howard, in our model here, where is the spinal cord itself? That very important.
This is the front of the spine, so these are the vertebral bodies, these are the discs, this is the back of the spine, and the spinal cord and the nerves are in this channel, so it's completely surrounded by bone. In other words, it's protected, because literally the spinal cord and the nerves really run down almost through the dead center of the body. So it's very deep and it's very well protected, as you might imagine.
Okay, so you mentioned that back pain, neck pain, etc. is the most common reason for disability or time off from work. Everybody feels back pain or neck pain at least one time in their life, but certainly not everybody gets an operation, correct?
Oh, absolutely.
So what are the modalities that we start with if someone has back pain, neck pain, and goes to see their doctor?
Well, whenever you present to a doctor or just even have an episode of back pain, there's what I consider to be sort of 3 stages of care. Stage 1 is time, anti-inflammatory medications, avoidance of the hurtful activities, and rehabilitation. We've sort of in the past 10 to 20 years gotten away from what we call the passive care model to the active care model. I mean, we're more likely to treat you like we would if you're an injured athlete. Meaning that if you have an injured body part like the spine, we'll generally rest that area. Maybe we might ice it for a couple days. Then after 2 or 3 days, we might start stretching those tissues. But hopefully by day 5 or 7, you're actually starting to do some muscular re-education, some strengthening, as opposed to the passive care model. like we used to do 30 years ago, when they'd actually put people in the hospital and put you in traction for 3-4 weeks. Now we're much more active or proactive as far as rehabilitating spinal injuries.
Okay, Dr. Howard, that's very helpful. And what I'd like to do is sort of vault forward and teach me about spinal operations, because I have a lot of questions for you. Now, what is it that we mean by a slipped disc or ruptured disc? Does that actually happen, that the disc can slip and press against the nerve, or it can tear apart and push against the nerve?
Well, slipped disc is sort of a slang term, but it basically encompasses all disc injuries. What a ruptured or herniated disc is generally a tear in the outer disc fibers, causing a weakness and some type of relative bulging. And there's actually 4 distinct types. There's a bulge, there's a protrusion, there's an extrusion, and a sequestered. Those are all progressively larger or progressively more severe herniations. But basically, when the disc material comes out and increasingly encroaches into the space where the nerves are, causing nerve pinching. Those are all examples of slipped disc.
Okay, so is that the same or different than when you use this term spinal stenosis?
Spinal stenosis also refers to any condition which narrows the channel where the nerves are. Spinal stenosis, though, usually is more often a function of normal aging, where as we get older, we develop arthritic bone spurs, and slowly over the years, those bone spurs grow and narrow the channel where the nerves are. So stenosis is usually more bony problem or bone spur, which is age-related, as opposed to herniated discs. They're most prevalent between the mid-20s and, say, the early 50s. And then spinal stenosis is more common in the 50s, 60s, 70s, 80s.
Okay. Well, Dr. Howard, is it true that, well, for certainly not everybody who has back pain will get an operation, but is it true that if someone has a nerve deficit, and in other words, if the disc or part of the bone spur is pushing on the nerve to such a degree that they have an actual deficit, for example, a foot drop, or hand weakness, is that true that that's an urgent indication for an operation, or can those people be treated conservatively as well?
Well, even those people can be treated conservatively initially if the deficit isn't progressing. The thing we worry about most is weakness, like a foot drop, David. That implies somebody's unable to walk on their heels. Their foot slaps down because the nerve's pinched, which powers that muscle, which allows us to walk on our heels. If that condition is worsening, that person needs to be taken into surgery right away to relieve that nerve pinching, to try to maximize the chance of getting that recovery. If it's not worsening, we can give that problem anywhere from 4 to 6 weeks to improve, because many times it does. But if it hasn't improved by 6 weeks, that usually in itself is a situation where I would tell the patient, hey, I think we need to go in there and relieve that nerve pinching to minimize the chance of you having a permanent weakness or a permanent deficit.
Okay. Dr. Howard, there's another term that I hear almost constantly, and that's sciatica, correct? Mm-hmm. Now, does that mean foot drop, or is it just a pain, an uncomfortable pain going down the leg? What do we mean by sciatica?
Well, true sciatica is leg pain, and true sciatica is pain that starts in your buttock region and goes down the leg. Actually, true sciatica has no associated back pain. It's all buttock and leg pain. It can very often include some numbness or weakness. It can include foot drop, but it doesn't necessarily have to. Sciatica just means radiating leg pain that's coming from the back.
Okay, and the sciatic nerve is involved? Maybe we can teach the audience what we mean by the sciatic nerve.
Well, in our lumbar spine, each of these little channels, this little hole to the side, for example, is called the foramen, and we have 5 or 6 nerves that come out of these channels. They combine to form one nerve, the sciatic nerve. So the sciatic nerve actually doesn't form until it's deep on our buttock outside of the spine, and then the sciatic nerve runs down the leg. So anywhere where there's pinching along that way, any of those 5 or 6 nerve rootlets that come out of the spine can cause sciatic pain and sciatica or sciatic nerve dysfunction.
Okay, so if someone has a foot drop, and I'm going to ask you about this term lumbar laminectomy that I know you're really good at, skilled at. You're fellowship trained in spine surgery. Well, what is it that we mean by a lumbar laminectomy, and what are the indications for it?
Well, the indications that the lamina is this part of the bone and back of the spine. So if we are forced to have to do a back operation, like for a nerve pinching situation, we generally would go in the back of the spine and we would take away some portion of this bone called the lamina. Well, the medical term for that is laminectomy, or if we do so partially, it's laminotomy. That allows us to get down where the disc is, gently move the nerve to the side, and take away the herniated portion of the part that's pinching the nerve. So that's called a laminectomy or a laminotomy and a microdiscectomy. The good news is, like with all of my spine procedures, we're doing so through smaller incisions. It's microsurgery. We're using the microscope. And that operation nowadays is usually outpatient surgery. You go home the same day.
And that's actually a tremendous, that's progress, isn't it, compared to the way back surgery was 20 years ago?
Well, 30 years ago, my father, for example, was threatened to have a laminectomy, and he was told he'd be in the hospital for 7 to 10 days. Now, for the same problem, he might be in the hospital or the outpatient surgery center for 7 to 10 hours, or maybe 4 hours. So,
okay.
So there's been real progress there.
Smaller incision, and you use the microscope. And you mentioned that you actually have to hold the nerve or retract the nerve to the side while you work on the bone. That sounds like a fairly tense or tricky operation.
Well, we do some bone removal. That allows us to get down where the nerve is. We visualize the nerve with the microscope. We very gently mobilize or tease the nerve off the disc portion that's offending. We'll take that disc portion away, but it's in my experience, in my opinion, it's much safer to do that while you're actually there looking with the microscope. There are some techniques where it's done arthroscopically, where you just go in with something that looks like a pin with a camera at the end. But that's not quite as safe because you don't have the same direct visualization of the nerve.
Okay. Dr. Howard, there are other conditions where the vertebral column will collapse or fracture, correct? And I think there's a relatively new procedure called a kyphoplasty.
Correct.
Is that right? Can we talk about that? Can we teach our audience what that is?
Yeah, kyphoplasty is a new procedure designed for compression fractures. Very common, David, in older people who have osteoporosis. They have weak bone, they've lost some mineral, and very often it becomes weak enough where they just start having vertebral collapse just due to the normal stresses of everyday living. That can be very painful. It doesn't always cause pain, but it can be painful. Kyphoplasty involves, again, not even a surgery. It's just a needle procedure. We put little needles into the broken vertebra. Through that, we insert a small balloon. We inflate the balloon to create a little cavity, and then we fill that cavity with bone cement. The bone cement stabilizes the broken vertebra immediately, and in about 90% of cases gives us immediate pain relief.
Excellent. That's very different than telling someone to go home and lay in bed for a week or two. Isn't that correct?
Well, exactly. That's the whole idea. The problem with laying in bed for a week or 2 or 3 or 4 is all the potential complications, bed sores, pneumonias, deep vein thrombosis. So there's a lot of complications that can come with that. So if we can keep somebody mobile and keep them up and active and obviously alleviate their pain much more rapidly, then that's a very beneficial procedure. We've done a lot of those here in our community, David, over 1,000 now.
Over 1,000 kyphoplasties?
Yes.
That's amazing. Now, Dr. Howard, you know, in all joints around the body, and I do hand surgery, as most of my audience knows, will oftentimes try to resurface a joint instead of fusing it. Now, are you tending to try to replace the disc, or are there cartilage stimulating substances that you might be able to inject in there to encourage new growth of cartilage, or do you just tend to take out a disc, and when do you do fusions, etc.? So let's talk about disc disease for a while, if we could.
Well, disc disease is normal, number one. We call it degenerative disc disease, but it's just normal wear and tear. It happens for everybody. Thankfully, only a small percentage of people is that a chronically or a very painful problem or very disabling. For a very small percentage of people who have that with very high levels of pain and disability, we do have to consider sometimes some reparative surgeries or some reconstructive surgeries. The old-fashioned one, which you referred to in hand surgery, and we've been doing orthopedics for 100 years, was fusion. Originally in the spine, that was done for TB or tuberculosis or Pott's disease. But the problem with fusion is that, and here's a model of some of the hardware we put in when we fuse, the problem with fusion, it makes that part of the spine stiff and rigid, creates additional stressors to the next level, and that leads to an accelerated rate of injury and degeneration and subsequent surgery in the next segment. So a very exciting area in spine surgery are the new disc replacements. Here's a model of one in the neck. You can see how this articulates and moves. It maintains normal motion, very much like the hand replacements you do. And here's what it looks like in the lumbar spine. So especially for a younger person, I mean somebody, you know, under the age of 65, for example, maintaining this kind of motion if you have to reconstruct their spine is advantageous because it lessens all those risks that go along with fusion.
Well, Dr. Howard, is that the same for the neck as it is, say, for the lumbar spine? I would think biomechanically the neck has different stressors, and we expect the neck to move differently than we do, say, the lumbar spine. Is spinal surgery the same for the neck as for the lower back, or is it different?
Well, it is different. Here's a model of kind of the tried and true standard neck operation. For example, this is a plate on the neck with a two-level fusion, and that's a very successful operation called the ACF, anterocervical fusion. The problem is when I move the spine, notice how that section doesn't move at all. In the neck now, the data is clear. If you have even a one-level fusion in the neck, there is a 25% incidence of having adjacent level surgery within the next decade. So if you have your first level operated on your 40s, you don't really want to come back and have another level operated on your 50s, another level in your 60s, another level in your 70s. That's why for a younger person, the mobility that you maintain with a disc replacement and minimizing those junctional stress transfers is better. There is more mobility in the neck, you're absolutely correct, but there's a lot less stressors in the neck because the neck only has to hold up the head, whereas the lumbar spine is really taking all the forces and all the weight of the entire body. So the forces in the low back are much greater, though the mobility of the motion segment is less.
Okay. Dr. Howard, we have about a minute left. I want to make sure that I give out your phone number and our website. Dr. Mark Howard, you are a fellowship-trained spine surgeon, board-certified orthopedic surgeon. Now, can we give out a telephone number or website if somebody has questions?
The website is markhowardmd.com.
markhowardmd.com. And you are here in Monterey, California.
I am. And the phone number is 831-655-5380.
Okay. Now, Dr. Howard, in just the few seconds we have left, can you talk about microdiscectomy again? Now, you say it's a dramatic difference in the way we treat those people as compared to 20 or 30 years ago. Can you talk about the mechanics of it?
Well, everything in my field, I'm sure it's the same for plastic surgery, David, everything in my field is going less invasive. We're able to do as much or more surgery through smaller incisions. That's what microdiscectomy or microsurgery means. We're able to utilize the operating microscope and get magnification 10, 20, sometimes 30 times power. That allows us to either through a very small tube or very small incision, in some cases even just a centimeter or two, which is like a half an inch, go down and work on a structure 2-3 inches in depth. It's minimally invasive. There's very little tissue destruction, and that's why that's allowed us to take an operation that 30 years ago the patient stayed in the hospital a week. Now they're able to stay in the surgery center or the hospital for 4 or 8 hours and go home.
Amazing. Dr. Mark Howard, fellowship-trained spine surgeon, board-certified orthopedic surgeon. I appreciate very much you coming on the program and teaching us.
You're welcome. My pleasure.
Once again, this is Your Health television program. I'm Dr. David Morwood. I am a board-certified plastic surgeon. We're going to take a very brief pause for a very good cause. Thank you so much for being with us.